It's, well, anticoagulants. So I'm going to talk about these basic three groups of anticoagulants. And the tack I'm going to take, I think you can look at anticoagulants as like really, really complicated. we're not going to go here. You know, I weep silently every time I see this graph, and I don't think it's a level of detail that we need to know. And so I am going to go sort of very high level and very superficial, frankly, but hopefully include the stuff that is clinically relevant and stuff that I think will be clinically, appropriate for, the N exam. So I will start with heparin. Heparin is, as opposed to most medications that we use, is not one molecule. It is this gigantic group of different size molecules that inhibits coagulation factors and prolongs the PTT, right? So we know this, we know that it decreases coagulation and may increase bleeding. Low molecular weight heparin is much more commonly used these days, with heparin being reserved for very, very specific circumstances like pregnant women and things like that, or where you need an infusion that can be cut off, shut off very quickly before surgery or something along those lines. Low molecular weight heparin is just heparin, but selected for a certain size. And so instead of having this huge range, you have a smaller range, but it still is a big group of molecules. So, and obviously it's a group of lower molecular weight within the heparin group. The advantage of that is a couple. One, it has more factor 10 inhibition, which is preferable. And it has probably the big selling point for it, right, is it has a much more predictable effect on PTT. And so you don't need to monitor them for like you do with them. One thing that always seems to me like it's the opposite in my brain, I don't know why, but low molecular weight heparin has a longer half-life than unfractionated heparin. And it makes sense if you just think about the dosing regimen, instead of an IV infusion or a frequent, you can give yourself an injection, intermittently. But it just seems like a lower molecular weight and the smaller range should have a shorter half-life, but it doesn't have as much longer half-life. So those are just some of the things that are sort of unique about that. Now, overdoses of either of these are extremely uncommon, challenge accepted. There's going to be one person out there that's like injecting themselves with lots, but they're very, very rare. But bleeding complications from therapeutic use are not. So if you are trying to make someone, less, coagulate less, then, and you are successful, then if they fall down and may hit their head, they're going to have bleeding. So most of the time that we are trying to reverse these are not actually overdoses. They're just the person is bleeding and we would like to reverse it. So most of the time when someone is on heparin and they're having bleeding, we just, stop the bleeding, treat the blood loss with blood products. Neonates, again, very high risk. Neonates, for some reason, there's such a high risk for adults dosing or tenfold dosing errors, or, we just gave this neonate 5,000 units of heparin as a bolus because we read the wrong guideline or whatever it is. They can actually get exchange transfusion, which is something that we use in neonates, but rarely use in adults. Just because of the volume of blood in a neonate. So essentially take their blood out and replace with fresh blood that doesn't have heparin in it. And then the reversal agent is protamine. We very rarely use this, and its use is extremely complicated. But there are some rules that I think are reasonable to at least hear out loud once before your exam and then look up. These are none of these things would I commit, would I rely on my memory to just to remember and then and then write an order for, because these are, I can probably count the number of times I've used protamine, on a hand in my life. So it's extremely rare when you're giving a medication or an antidote that has potential toxicity, and you rarely use it. Just look it up. But for the test, you can't do that. So let's just go over some of the rules, right? 1 milligram of protamine neutralizes 100 units of heparin, and the max is 50 grams. So that is the classic. Those of you who have been around long enough to have calculated the very complex calculation to figure out how much your heparin bolus was supposed to be, and yet it always ended up being 5,000 anyway. That is the sort of 5,000 is sort of the standard dose, as the bolus, and that's where you max on your protein. Now, the half-life of heparin is pretty short, and you are supposed to actually figure out how much heparin is left. And so if you have, if the heparin was given 3 hours ago, you're supposed to say, well, that's how much heparin was there. And now it is 1/4 of that, because it's 2 half-lives, and you're supposed to give the dose for that. But this involves a pharmacist, please, and someone at the bedside doing this who knows exactly when it was given and exactly how much. For low molecular weight heparin, it's more straightforward. 1 milligram neutralizes 1 milligram of enoxaparin. And as I mentioned, you do have to do this based on the timing of the heparin infusion, or the time that the heparin was given. It's a fairly complex process. The protamine itself, if you give way too much, can cause bradycardia and hypotension, so that's problematic. It's also a allergenic substance, so a small percentage of people who get it will get anaphylaxis, but 0.2% is small, but it's not zero. So that also could be a good question on an exam, is you get protamine and that they have a reaction and it's allergic. That doesn't have to be an overdose of protamine. That could be just a regular dose of protamine. Okay, so warfarin, thank goodness, being used less and less. Inhibits activation of 27910 protein C and S. There's warfarin, and then there's the long-acting coumarins like brodifacoum, difenacoum. There's a whole bunch of others that have been historically used in rodent poisons. I think we are seeing, I'm curious what you guys think. I think we're seeing a lot less of these, because Home Depot and Lowe's and I forget a couple of other places stopped carrying any long-acting anticoagulants, even though apparently they're still available. I haven't been able to find any in any stores. So I think we're seeing a lot fewer of these. The difference between the long-acting coumarins and warfarin is simply that they're much, much longer duration of action. So, the way it kills a rodent, the rodents were starting to get a bit tolerant of the warfarin, but if it sticks around long enough, like brodifacoum, then it'll kill the rodent. The way it usually kills them is if they compress themselves, like to go through a small hole or under a door or something like that, then they'll develop bleeding. And so if it sticks around for months, then you're more likely to kill the rodent that way. So, another one of these, if you want to Remember that warfarin and all of the coumadins inhibit vitamin K epoxide reductase. Great. But I think more importantly than that is that this is a big cycle, and vitamin K gets activated, and that activates all of these factors. And then it recycles and activates them over and over and over again. And if you inhibit this step, then you don't activate vitamin K, and so you don't activate any of those factors. So if you did a factor concentration of all of these things, they would be normal. If you do a factor activation, then they are abnormal. So it's a little tricky kind of, it's the activation of the factors that's not happening. So they're not effective, but if you measure them, they'd actually do it. So, as I was saying before, Birdificum, the bane of existence for many decades. Birdificum and other rodent poisons were but we saw a lot more of them in the past. Very, very dilute. So the average was 5 milligrams per 100 gram of product, which means that a child would have had to eat hundreds of grams of Birdificum product to have a coagulopathy. So, almost none of them do that. If a 2-year-old sat down and chugged 2 full boxes of Birdificum pellets, well, then we probably have to send them in. They may develop a coagulopathy. However, there were cases, very unfortunate cases. You can still get it on Amazon now. Of course you can. There were cases of children who would go back and eat the pellets day after day, and they can get coagulopathy. The numbers for warfarin is you're unlikely to develop a coagulopathy unless your acute overdose is over 30 milligrams, and it probably needs to be a lot more than 30 milligrams. But that's the number that's sort of the low risk group. If you ingest less than 30 milligrams, you're not going to develop coagulopathy. And that is because you inhibit the activation of those factors, but you only do it until the warfarin is gone, which isn't that long. It's only a day or two. So by the time the warfarin is gone, you're activating factors again, and you never really lost activity. And back in the day when you used to coumadinize people, you would give them like 10 milligrams of Coumadin the first day, 10 the next, and then on the second day, 48 hours later, you can start to see that increase in the INR. One note, if this comes up in a clinical scenario or something like that, the most common cause of bleeding after coumadins, for long-acting coumadins, is hematuria. GI bleeding is much less common. So this came up when there were long-acting coumadins found in drugs of abuse, and the patients who were coming to the emergency department were coming not for any other reason, but because they had hematuria. And then once they figured out they had hematuria, they checked their INR, and it was really high. That was synthetic cannabinoids. Okay, so we use INR to diagnose it, and then if it's life-threatening bleeding, 4-factor PCC, if they didn't have 4-factor PCC, and also 4-factor PCC is kind of expensive, so there are some places that limit its indications. You can use fresh frozen plasma, but that is a slower reversal of INR than 4-factor PCC. So I think we'll always go with 4-factor PCC. If it's not available, small hospital, blah, 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 then FFP. And then life-threatening bleeding with Coumadin, 10 milligrams. The textbook says 10 milligrams of IV vitamin K. There's a fairly high reaction rate with IV vitamin K with anaphylactic reactions. And so if it can be given PO, it's absorbed almost as quickly as IV. Obviously, if it's a life-threatening, truly life-threatening situation, give it IV. If it's non-life-threatening, then try PO. What about those non-overdose elevated INRs? We get that every once in a while where someone has hematuria, they check their INR, they're on Coumadin, their INR is greater than 10. Oops. If they have serious bleeding, go back to just like it's an overdose, 4-factor PCC plus vitamin K. But there is a protocol for patients who have no bleeding. They're totally asymptomatic. They don't have hematuria. They just get their INR checked. It is 8. Well, if it is 8, you see the protocol here. And actually, from 4.5 to 1, you can give a small dose of PO vitamin K. I think I just left that out. But the recommended dose is 1 milligram of PO vitamin K. So there is a protocol. I don't think you have to have it memorized, but I do think it's important to know that it exists. It's published by the American Thoracic Society. And the reason why it's important is because the doses of vitamin K are much smaller than most of us would give. So if if you said, oh, this person has an INR of 12, I think a lot of people would give that person 10 of vitamin K. The problem is that 12, 24 hours later, their INR is 1, and it's never supposed to be 1. It's supposed to be 2.3 or 2.5 to 3.5, whatever their indication is. So most of the time, holding the warfarin is good enough, and only in very high INRs should you give vitamin K, and it's a pretty small dose. All right, I'm going to tackle the the other newer anticoagulants very, very briefly because I don't think there's a lot to say about them, honestly. The direct thrombin inhibitors, I mean, you could say hours worth about them, but I don't think it's all that important. The toxicity, bleeding. These are usually not overdoses that we're seeing. But if they are, a elevation of INR or PTT doesn't really correlate with bleeding. So if it's high, if they're not on these and their INR or PTT is high, they took it. That's fair. But it doesn't correlate with their risk of bleeding like it does with Coumadin. So what would we do? An acute overdose, maybe activated charcoal, I don't know, maybe gastric lavage, I'm not sure. But treatment, as mentioned before, the FFP and 4-factor PCC. But for dabigatran, and I think this is a really important one, dabigatran has a very specific antidote, and that is Praxbind or idursulfimab, and it's a monoclonal antibody to dabigatran. The company made the monoclonal antibody specifically for their product, this is an important one because it's very, very specific. Everything else is just treating them like they're bleeding, treating them like everyone else. The 10As, again, surprise, surprise, their toxicity is bleeding. What? They also get elevations of PT, INR, PTT. It doesn't correlate. If you had someone who's not on these meds and they took an overdose and their INR is high, it means that they took that overdose. It doesn't mean that they're going to necessarily bleed. So, same deal with this. If they just took an hour ago a huge overdose of, charcoal, maybe lavage, I suppose, treat their bleeding and their with 4-factor PCC, and then again, there's a specific antidote which is Andexo or Andexanet alpha, which can be used for the factor Xa inhibitors. And I think that's probably the depth that I would go for remembering these things, because I feel like you can go super, super in depth, or you can keep it very, very straightforward. And hey, Zane, as far as the Coumadin, the warfarin-based rodenticides, best I can find is they are still legal, but Home Depot, like the big Home Depot, Walmart, Lowe's, and I think it was Target, all don't carry any of them. So it's sort of this weird thing where it's like not banned and it's still possible to get, but I think the numbers are so are so much lower now because they're just not available in the common places people shop. Let me just share the screen again because your question about factor 10A inhibitors. Let me just put it up there for a minute. The two most common are rivaroxaban and apixaban. The other two I have never seen anyone on, but they exist. Stop sharing. All right, very good. I don't know. LAAC, is that you're talking about the
Superwarfarin.
Suzumab? Oh yeah, yeah. Yeah, it I don't know if they did that. Oh, because like why they stopped using the long-acting vertificum and things like that. Oh, okay. Makes a lot of sense because I know rodents when they are ill, they leave. One of the advantages of the coumadin-based rodenticides is that the rat doesn't die immediately. It just starts to feel ill, and then it leaves the nest. So it usually leaves the house and dies outside. So you don't have like a rotting corpse in your wall. That's like one of the big advantages because they start bleeding and then they feel like, there's like I don't know if you've ever had like, guinea pigs or hamsters or gerbils, they leave when they're sick and they're dying, they leave the nests, and it's supposed to be like an evolutionary advantage because they died of something, and so the rest of the group won't get it. But that's I've heard that as a theoretical advantage of the coumadins is that they start bleeding, they feel that they're sick, and they leave the house so they don't die in the house. So it makes a lot of sense. They make it out to the yard and then a hawk comes by. All right. Well, great. Thanks, everyone. I will hand it off to Zane. Zane, we just were doing this for about 20 minutes. So if you want to do a break now, I don't know how long
Did they have a break like 20 minutes ago? Was
they
that
had a break 20 minutes ago. Yeah. So that's your.
Yeah, I can just jump right in and
Sure.
do it. This lecture sometimes runs a little long, so
I figured as much. You got a lot more on that than I have for my talk. So.
All right.